Chapter 2 talks about the anti-inflammatory, anti-arthritis, and anti-gout drugs. This is a very short chapter. Um, so inflammation is a predictable set of tissue and blood vessel actions caused by white blood cells or your leukocytes and their products as a response to injury or infection. We talk about this when we talk about immunity and inflammation or the inflammatory process when we were doing med search 1, but we'll review it and we'll go over it again before we'll talk about the medication that we use to control inflammation. The inflammatory response. So there's like phases that our body goes through when there's an inflammation. The first one is the trigger for inflammation. Of course, there's always going to be a cause, right? For example, you sprained your ankle, so that would be the trigger for the inflammation. Then there's going to be phases of the inflammatory response. And what are they? Remember your chemical mediators? So the damaged tissues, it's going to call those white blood cells and all those inflammatory chemical mediators that causes the inflammation. What are those mediators? Those mediators that causes the inflammation, they are your kinins, your prostaglandins, histamine, and your TNF or your tumor necrosis factors. Your histamine, so let's talk about histamine because we have medications that are like antihistamines, right? It could help also with the inflammation. Your histamines, it acts on blood vessels in the injured area. They cause the blood vessels to dilate and leak the fluid from the capillaries. So that's why that area is going to be swollen because of that histamine. It's causing the blood vessels to dilate and then the fluids will leak from the capillaries. Okay? What are the symptoms of your inflammation? We already know redness, warmth, pain, right? And then the loss of function. Maybe you can't even move that area. Okay, medications that we use for inflammation management. You have your non-steroidal anti-inflammatory drugs or your NSAIDs, your corticosteroids. Remember, I always tell you guys that when you hear corticosteroids, I need you guys to ingrain it in your brain that corticosteroids is anti-inflammatory. We also have your DMARDs or DMARDs, your disease modifying anti-rheumatic drugs, and then your anti-gout drugs. Okay, first up, your non-steroidal anti-inflammatory drugs or your NSAIDs. The most common one, your aspirin. Look at your book, page 228, table 12.1. These are your NSAIDs for inflammatory problems. How do they work? What are the actions? Actions is unknown, but they may block prostaglandins, analgesic, anti-inflammatory, and there's an antipyretic effects. Antipyretics is if there's like a warmth or fever, right? Your pyretics, that's your fever or warmth. So antipyretics is actually helping if there's a fever. Why do we use it? Where do we use it for? Uses are for rheumatic disease, degenerative joint disease, your osteoarthritis, and acute musculoskeletal problems. But the most common adverse reactions is your GI problems. Okay, let's go over them. Page 228, table 12.1. You have your aspirin, you have your ibuprofen, ketorolac, nabumetone, naproxen, and paroxysm. So, nursing implications, what I need you guys to remember here is the second one. Warn patients that these drugs all increase the risk for bleeding because they all interfere with the platelet function of the clotting process. You remember, or if you recall, when we were talking about aspirin, I told you guys that aspirin, you know, it's an NSAIDs and we use it for inflammatory problems, right? But now it's very common that we use your aspirin, your low dose aspirin, 81 milligrams, as an antiplatelet to thin the blood, right? To decrease the risk for blood clots. So you warn your patients that there will be an increased risk for bleeding because of that reason. And then third one, you remind the patient to stop taking aspirin 1 week before any surgical procedure, including your dental procedure, because of the risk for bleeding. And then you tell the patient to report stomach or abdominal pain or any signs of blood in the stool to their prescriber, because these drugs all increase the risk for GI ulcer formation. So this is all about monitoring your patient for bleeding. And the next one, you tell the patients not to take NSAIDs while taking Coumadin, warfarin, because the risk for bleeding is then so severe that hemorrhage and strokes are likely. So be mindful for those patients that are taking your Coumadin or warfarin, and then they're going to take the NSAIDs, your aspirin or naproxen, because the risk for bleeding is then so severe, okay, that the patient might be hemorrhaging or stroke can happen. Okay, and then you tell the patient who are taking any NSAIDs except aspirin to weigh themselves at least twice weekly and keep a record, because these drugs increase salt and water retention. Remember your heart failure, okay, heart failure patient. So if they're taking this NSAIDs except your aspirin, make sure they're weighing themselves at least twice weekly to monitor if they are retaining the salt and water. And because if they do, it can worsen the heart failure and your hypertensive patients. Instruct patients to take NSAIDs with food to help prevent stomach irritation. Remember that the adverse effects or side effects of this medication is GI problems. So take your NSAIDs with food. And then teach patient to drink 2 to 3 liters of fluid daily while on NSAIDs to ensure good flow to the kidneys. Because all of these drugs, they can cause kidney damage. Diabetes patient, you instruct them to check blood sugar levels more often, because these drugs can increase the risk of hypoglycemia, the low blood sugar, in patients who are taking oral anti-diabetic drugs. So your patient that are taking your metformin and those anti-diabetic drugs, so you tell them and educate them, okay? Before we continue with corticosteroids, look at page 228, your common NSAIDs for inflammatory problems, the bottom ones. You also have your COX2 inhibitors, and it inhibits this chemical mediators, COX2, helping with the inflammatory process. You have your Celecoxib or your Celebrex and your Meloxicam, which is your Mobic. Nursing implications, highlight the first one. Before the first dose of your Celecoxib, ask whether the patient has an allergy to sulfa-based antibiotics, because a patient allergic to sulfa is likely to also be allergic to Celecoxib because it contains the same chemicals similar to your sulfa. And then you tell the patient that they should take these drugs with a full glass of water or a small amount of food. Remember GI upset as a common adverse reaction or side effects. Okay. And then lastly, please highlight the fourth one. Avoid giving these drugs. Your COX2 inhibitors, avoid giving these drugs to anyone who has angina, who smokes, or who has severe coronary artery disease, because they increase clot formation and the risk for heart attacks. So, looking at the one on the top, your NSAIDs, they are at increased risk for bleeding because it thins the blood. It helps thins the blood because it's an antiplatelet as well. Now your COX2 in the bottom, this one increase the clot formation. It's the other way around, right? It increased the clot formation and the risk for heart attacks. Okay, let's go over your corticosteroids. So how does corticosteroid works? Well, the action is these drugs inhibits enzymes and proteins that allow the COX-1 and COX-2 enzyme systems to start and continue the arachidonic acid production of inflammatory mediators. So it stops something in between, or it stops for the inflammatory process to continue. They are very powerful in decreasing the production of all known mediators that trigger inflammation. The systemic forms of these drugs disrupt the normal functions of other products from arachidonic acid that are helpful and protective. So it works by decreasing those mediators that we talk about that triggers the inflammation and continue the inflammatory process, right? Okay, expected side effects. Number one for you guys to remember when we're giving corticosteroids is the sodium retention. Okay, the patient is going to retain sodium. There will be increased blood pressure. Another thing to remember is your weight gain. Very common with corticosteroids. There are even instances where your patient is going to refuse taking this medication because they are gaining so much weight. Okay? Other side effects or adverse reaction, you have your bruising, your reduced immunity or your adrenal gland suppression, and reduced it says the same thing, reduced immunity. Okay, so let's go over your common corticosteroid drugs. In page 231, table 12.2, you have your dexamethasone, prednisolone, prednisone, hydrocortisone, methylprednisolone, betamethasone, hydrocortisone, triamcinolone. So again, corticosteroids end with ONE, your owns. Okay, so that's one thing to remember. Corticosteroids ends with ONE, your own. Let's look at the nursing implications. Nursing implications. Check the order carefully because different types of corticosteroids come in different strengths and are not interchangeable. It's very true. You have some corticosteroids that are taken by mouth. You have some corticosteroids that are taken IM, IV. There's even ointments for topical. So make sure you are checking the order very carefully when you're giving the corticosteroids because they have different strengths. They have different doses and route. Different strengths meaning if you look at this one, your betamethasone 0.1%, and then you go to your triamcinolone which is 0.025% to 0.5%. So they have different strengths, okay? Okay, doses must be tapered rather than stopped suddenly to avoid adrenal insufficiency. So remember that your corticosteroids, our body is actually producing these corticosteroids normally, right? So if you're giving that corticosteroids to the patient, your adrenal glands, they are the ones that are responsible for this corticosteroid, your cortisol. So if they're so used to receiving this medication, if you stop it suddenly, then your adrenal glands is going to be in shock. It's gonna be like, oh, what happened to the high level of cortisol? So it's gonna act up. It's gonna be a problem with your adrenal because they're so used to that cortisol level or their steroids level in the body, and if you stop it suddenly, then your adrenal gland is going to be in shock. All right, let's continue. Oral drugs should be taken with food or milk to reduce for gastric ulcers. You check the patient's blood pressure and weight. Remember, weight gain is one of your side effects. Assess for infection. Let's talk about this. Corticosteroids reduces your immunity. right? We all know that by now. So that's why you are going to check your patient and assess frequently for infection, because these drugs reduce the immune response and increase the susceptibility to infection. Okay, when patients are taking these drugs long term, you be sure to handle the patient carefully and not only tape to the skin, because these drugs increase bruising and thin the skin. Never apply a topical corticosteroid cream, ointment, or lotion to a skin area that has indications of infection, because the infection can spread. Make sure to monitor blood sugar regularly. Another thing to remember, okay? With diabetes or pre-diabetes, corticosteroids reduce the sensitivity of insulin receptors. That's why your diabetic patients, the diabetes, the blood glucose level is going to be up, because your corticosteroids decreases or reduces the sensitivity of insulin. So you monitor your patient because their blood sugar might be up. Okay? All right. Patients may experience a change in mood while on corticosteroids. Make sure to notify the prescriber if the patient has significant mood changes to reduce the risk of psychotic reactions. And then for topical forms such as lotion, creams, and ointments, make sure to apply a thin layer to the affected area as directed to avoid giving too large of a dose of corticosteroids. Okay. Before we continue to DMARDs, your DMARDs, let's look at page 232. Your common side effects of your corticosteroids. So, common side effects of systemic corticosteroids, you have side effects that can occur as soon as 1 week of therapy. You have your acne, sodium and fluid retention, your elevated blood pressure, sensation of nervousness, difficulty sleeping, and emotional changes. They cry very easily. And then you have your side effects that can occur within a month after therapy, your weight gain, your buffalo hump, we'll talk about that in a little bit, increased risk for GI ulcers and bleeding, fragile skin that bruises easily, loss of muscle mass and strength, thinning scalp hair, increased facial and body hair, increased susceptibility to colds and other infections, and then your stretch marks. So look at your figure 12.3. Okay, so if you look at it, this is what we call the Cushingoid appearance. So they look like those patients that have a Cushing's disease. Um, they're gonna have that buffalo hump. You look at that hump in the back, we call it buffalo hump. There's going to be increased body and facial hair. They're gonna gain weight. Remember, corticosteroid can cause weight gain. Their face is gonna look like moon face. They're gonna have acne and then stretch marks. Even in the back, if you look, they're gonna have acne in the back. And then there's what we call the truncal obesity, where their upper body, the torso part, it looks like they're obese. Okay? But then if you look at these extremities, you're gonna see the extremity muscle wasting and it's gonna be weak. Okay? All right, DMARDs. So, disease modifying anti-rheumatic drugs. How does it work? It works by decreasing or suppressing the inflammatory response, and in cases of rheumatic arthritis, it slows down the progression of disease and preserves joint function. If you look at page 235, table 12.4, your disease modifying anti-rheumatic drugs. These drugs reduce the progression and tissue destruction of the inflammatory disease process by inhibiting your TNF. We talked about TNF earlier, one of your chemical mediators with inflammation in the inflammatory process, your tumor necrosis factors. As a result, the pain is relieved, physical function improves, and tissue damage is reduced or delayed. So, what are the medication under your disease-modifying anti-rheumatic drugs? You have your Humira, your adalimumab, or your etanercept, or your Enbrel. Nursing implications. Well, expected side effects or adverse reactions, the injection site reactions, and then the immune response reduction. There will be a reduction in the immune response again. So nursing implications, the first dose of an injectable DMARD should be given by a healthcare provider or an RN because the risk of severe allergy. But we monitor the patient every 15 minutes for the first 2 hours to detect adverse reaction. So the first time that you're going to give this medication, your DMARD, it should be a healthcare provider or an RN. And then we are going to monitor the patient every 15 minutes for the first 2 hours to see if there's an adverse reaction. Then you're going to tell your patient that injection site reactions, it might be red. There might be pain and swelling and itchiness, okay? But it will typically subside in a few days. Make sure you rotate your injection sites and then you read administration directions very carefully before giving to avoid improper dosing. Do not rub the site after giving the injection. And then for patients with psoriasis, make sure not to inject in any lesions because drug absorption is delayed in these areas and the lesions may mask skin reaction to the drug. So if you're gonna give the injection, make sure it's the skin is intact where you're gonna give it so you can monitor for those adverse reaction if there is one, right? Do not give these drugs to any patients with an active infection, including local infection, because the drug reduces the immune response and it can make the infections worse. Tell your patients to report any signs of infection to the healthcare provider immediately because the drug reduces the immune response. We already know that. Patients who take these drugs before surgery may have greater risk for infections post-operatively because the drug reduces the immune response. And then, lastly, you teach your patient that it is not unusual to experience a mild headache while taking this drug so that they will not be alarmed by this side effect. So there might be some headache or inflammation that they will feel, but you educate your patients so they are ready for it. Okay, anti-gout drugs. Anti-gout drugs, we'll talk about that. Go to page 237. But before we go to the medication, let's talk about gout first. What is gout? Gout is a metabolic disorder that causes a person to either make too many uric acid crystals from the proteins that they eat or to not eliminate the crystals in the urine. These crystals then deposit into the joints, causing arthritis symptoms of pain, redness, and swelling. Okay, this joint damage is very, very painful. Very painful to the person, okay? So, what drugs do we give for your gout? You have your uric acid synthesis inhibitors. How does it work? It prevents gout and reduces gout symptoms by lowering blood uric acid levels through inhibiting the enzyme that converts the purine or proteins into uric acid. And then it gets excreted from the body, right? Okay, what are the drugs? What are the medications? You have your most common one, allopurinol. But you also have your febuxostat or your Uloric. Nursing implications, you take this medication after a meal to prevent GI side effects. You wait at least 3 hours after taking an aluminum-based antacid before taking allopurinol because the antacid inhibits its absorption. So drug interactions, your aluminum-based antacids, you take it 3 hours after taking the antacid before you take this medication. If patient is taking warfarin, your Coumadin, they will need frequent monitoring with your INRs, your blood draw, because allopurinol interferes with the metabolism of your warfarin. Do not give this drug to a breastfeeding woman because the drugs do enter the breast milk and their effects on the baby are not known. Your febuxostat, can be taken any time of day regardless of meals. You teach the patient to drink plenty of fluids to dilute uric acid and prevent kidney complications of the drug. And lastly, you teach the patients to keep all appointments for laboratory tests to monitor for drug effectiveness and toxicities. And that's it for this chapter.